Good afternoon, everyone. Welcome to this nutrition webinar. Thank you for being here with us today in this update information related to pediatric nutrition. Before we start, I want to share with you some logistics information about this webinar. Today, we're going to broadcasting through those two platforms, the Zoom and YouTube. Both platforms have a section for question and answer, and here in the YouTube, you can see below the bar will show you the Q&A section. The topic for today is going to be lactose intolerance in 1 to 5 years old children by Dr. Yvan Vandenplas. Dr. Vandenplas is a medical studies at Brugge University in Brussels and trained in pediatrics at the same university. He became the head of the unit of pediatric gastroenterology and nutrition in the '87 and is head of the Department of Pediatrics at the University of Hospital of Brussels and had the chair of pediatrics since 1994. His PhD thesis was on esophageal pH monitoring for gastroesophageal reflux in infants and children in April '91. As over 500 publications listed in medicine amount, which many papers and on infant nutrition. He is now associated editor of the Journal of Pediatrics, Gastroenterology and Nutrition and Nutrients. Let's welcome Dr. Vandenplas. Doctor, the floor is yours.
I'm Dr. Vandenplas, and it is my pleasure to welcome you on this presentation on the impact of lactose intolerance in older infants above 1 year or toddlers, so lactose intolerance in 1 to 5 year old children. But let's start with the beginning. The best way how to feed all infants is, of course, breastfeeding. Exclusive breastfeeding up to the age of 6 months is the recommendation of the World Health Organization. And what is typically on breastfeeding is that it is very rich in lactose. Breastfeeding contains about 53 to 61 grams per liter of lactose. And the World Health Organization recommends to go on with breastfeeding up to the age of 2 to 3 years. So it's obvious from this aspect on mother's milk and the recommendation of the World Health Organization that children are tolerant to lactose up to the age of 2 to 3 years. Now, what is lactose? Lactose is a beta-galactosyl 1.4 glucose. It's, as said, the main carbohydrate in human, but also in mammalian milk. And human milk contains here, according to this slide, it's even higher, up to 7 grams of lactose per 100 milliliter. And in cow's milk, it's relatively lower. So mother's milk especially is very high in lactose. Now, lactose is not always absorbed by young infants. So there can be a physiological lactose absorption during early life. But the term infant normally is able to digest about 1 liter of breast milk every day. And of course, a term-born baby weighs 3 kilograms. Let's take 4 kilograms, drinks 150 milliliters per kilogram. Let's take 200 milliliters. That means 800 milliliters a day, far below the 1 liter. So lactose is split by lactase, which is present on the epithelial surface, in galactose and glucose, which are then two carbohydrates which are absorbed. Lactase is, in fact, lactase fluorescein hydrolase. So it splits the lactose in the D-glucose and D-galactose. So it's an enzyme which is present on the small intestinal brush border. It's a lactase gene which is located on chromosome 2. It's a member of the beta-galactosidase family. It's expressed by mature enterocytes. Highest expression is in the mid-jejunum. And it also hydrolyzes fluorescein and some dietary glycolipids. And the peak lactase activity is in term-born infants. Lactase is present from 35 weeks onwards in gestation. So really preterm-born infants have difficulties in digesting lactose because lactase is physiologically only present relatively late in fetal life, while the gastrointestinal villi develop already from 14 weeks of gestational age. And typically is that the lactase is present on the top of the gastrointestinal villi. So how does it normally work? Is that lactase splits lactose to the galactose and glucose, which then is absorbed. That's what is illustrated also on the left part of this slide. What is shown on the right part of the slide is what happens if lactose is not absorbed and reaches the colon, where it's fermented in the large intestine by bacteria which are present. And then as a result of that fermentation, acetic acid, lactic acid, CO2, and H2 are produced. And that results in loose stools, bloating, flatulence, and abdominal pain. So in fact, it's the prebiotic effect of lactose that is not absorbed, the fermentation by the colonic bacteria, which may result in symptoms caused by the presence of lactose in the colon. So lactose is a conditional prebiotic. Lactose is fermented by colonic bacteria in infants in case of a physiologic malabsorption, and in individuals with lactase non-persistence, so with a lactase deficiency. The lactose is fermented by ileal and colonic lactic acid bacteria, and therefore there are prebiotic effects of lactose on stool consistency, improved fecal biodiversity, and potential benefits for early immune development, because of course when the lactose is fermented, the fermentation process results in increased levels of bifidobacteria in the gastrointestinal microbiota, and that's what we want, because bifidobacteria are necessary for the development of a well-balanced immune system. Also important to realize is that there is a difference between lactose malabsorption and lactose intolerance. So lactose intolerance is the appearance of gastrointestinal symptoms such as nausea, cramps, abdominal pain, distension, flatulence, diarrhea after ingestion of lactose. And lactose malabsorption is what happens when there is an appropriate of lactose an appropriate amount of lactose not absorbed, but without causing symptoms. So lactose malabsorption is not necessarily accompanied by the clinical diagnosis of lactose intolerance. What about the clinical classification of lactose intolerance? There are four main clinical types: congenital lactase deficiency, what we call also ataxia, developmental lactase deficiency, secondary lactase deficiency, and lactase non-persistence or hypolactasia, the primary late onset. Congenital lactase deficiency is extremely rare. It's a few cases which have been reported, mainly infants in Finland, and a locus gene has been identified. And the symptoms are very severe and occur short after birth. The developmental form of lactase deficiency is seen in preterm babies born before 36 weeks of gestation, because, as I said, the lactase only develops and at clinically significant levels from the age of 35, 36 weeks onwards. What about slow maturation? Does it really exist? In the first year of life, a partial malabsorption of dietary carbohydrates may be observed, and that may be caused by a slow maturation of the lactase, which gets to the normally observed levels in term-born infants at a later age, and that has been hypothesized to be, for instance, involved as a cause of colic, which then resolves at plus minus 3 months of age, because at that age then the lactase activity becomes at a peak level. But very frequently, lactose malabsorption and lactose intolerance is also caused by other diseases than lactase deficiency. So that's what we call secondary lactose intolerance. And whatever damage that is caused to the gastrointestinal mucosa can cause a secondary lactose intolerance. So viral gastroenteritis can cause a transient lactase deficiency. Treatment is then short-term lactose restriction. Cow's milk allergy, the same, and celiac disease, the same. So very strange is that when you look for it, there is little to no literature available about the time needed by the gastrointestinal mucosa to recover from these damages. So the duration of that lactose restriction during secondary lactose intolerance, allowing the mucosa to heal, the duration of that healing period is not really known. But the major topic of the presentation is, of course, the primary late onset hypolactasia, so or what is called the lactase non-persistence hypolactasia. It's the normal condition for most human beings, because as illustrated on the map on the right part of the slide, you see that in the major parts of the world, there are a lot of people with lactase non-persistence, which means late onset lactase deficiency, and proportional fewer people in which the lactase remains persistent. This is another way how to present the prevalence of lactose intolerance. So in adults, the prevalence of lactose malabsorption is about 70%, with the lowest rates less than 5% in the Nordic countries, and the highest percentage up to 100% in the Korean and Chinese populations. In children aged 1 to 5 years, which is of interest for us today, primary lactose intolerance prevalence ranges from 0 to 18–20%, and the prevalence of secondary lactose intolerance from 0 to 20%. And as you can see illustrated on this slide, also the prevalence of lactose malabsorption is also very high in Africa. So some data from the USA, where a lot of adults are lactose intolerant. So 30 to 50 million of adults are lactose intolerant in the USA. 90% of them are of Asian origin, 80% African origin, 60 to 100% Native Americans, 53% Mexican Americans, and the prevalence in Caucasian is about 15%, again indicating the difference of lactose intolerance, late onset lactose intolerance, depending on the genetic background, and much lower people from Caucasian origin. So summarizing, late onset of adult type primary lactase deficiency or hypolactasia occurs in 70 to 100% of the population worldwide, depending on which area you're studying. The start of that lactose intolerance is between 2 and 20 years. It's relatively low in Caucasian, 5 to 10%. It's autosomal recessive, and 5 to 10% of the lactase activity remains. So there is always a residual lactase activity. It's never zero. That's why complete lactose abundance is, or a lactose restriction is not needed. So in the majority of the population, lactase activity falls between the ages of 3 and 7 years old to a level that is approximately 10% of the childhood value, and it remains low through adulthood. So this slide again looks at lactose malabsorption prevalence in children and the prevalence at specific age in certain ethnic and racial population varies, as illustrated on this slide. And I'll let you just look at the figures and the origin, indicating what I highlighted before, that depending on genetic background, the percentage of lactose malabsorption differs substantially. So primary late onset hypolactasia is an autosomal recessive condition that is characterized by a gradual reduction of lactase activity, but it does not occur before the age of 2 years, or very exceptional. Mostly, constitutional lactase deficiency manifests itself after the age of 5 to 6 years in white populations and sometimes earlier in non-whites. In some racial groups, it does not occur before adolescence. So as highlighted before, Europe prevalence about 2% in Scandinavia, with up to 70% in the southern parts of Italy. America, white population, more or less 20%, Asia, close to 100%. So lactase deficiency is the result of a mutation of a regulatory gene for lactase that has been postulated to explain the delayed onset of the hypolactasia. Continued exposure to milk can to some extent affect the expression of the regulatory gene. What are the symptoms? Symptoms suggesting lactose malabsorption are nausea, flatulence, loose stools. Symptoms of adult-type hypolactasia increase with age, with many patients developing symptoms of lactose intolerance in adolescence and adulthood. They start briefly after consumption of milk. The time lapse between consumption of milk and appearance of symptoms is most of the time quite short. Heterogeneity in response among patients does occur, so symptoms are in general related to the amount of ingested lactose. So non-absorbed lactose is fermented by the gastrointestinal microbiota. That results in an osmotic effect, which causes watery acid diarrhea and results in the production of lactic acid, short-chain fatty acid, mainly hydrogen, carbon dioxide, and methane. And the production of gas is the pathophysiologic mechanism causing symptoms such as abdominal pain, cramps, borborygmy, bloating and flatulence, nausea and vomiting. Of course, there are a lot of differential diagnoses of lactose intolerance, such as infections, which are of course prevalent in tropical or countries, gastrointestinal disorders, inflammatory bowel disease, psychological factors, miscellaneous such as endometriosis and endocrine tumors, malabsorption such as celiac disease and other conditions. And of course, dietary factors also play a role. So it's a huge, broad differential diagnosis of different conditions causing exactly the same symptoms as lactose intolerance. So how do you diagnose lactose intolerance? Well, by taking a good history and observing a response to diet and re-challenge the patient. You can also measure stool pH and measure reducing carbohydrates. You can perform a lactose tolerance test, which is hardly ever performed anymore. The most popular diagnostic test today is the lactose breath test, and lactase, the enzyme itself, can be measured in duodenal biopsies. What we know is that there is a very poor correlation between the different diagnostic possibilities. And there are reasons for that, because lactase activity gives you some local information of a few 2-3 square millimeters, so very local information, while the lactose tolerance test gives you information of the complete intestine, just as the lactose hydrogen breath test. So that's why there can be a heterogeneity in the results of the different diagnostic tests for lactose intolerance. Important to realize also is that not one diagnostic test separates primary from secondary lactose intolerance. So be always aware that the child may not suffer from late onset congenital lactase deficiency, hypolactasia, but that a child may suffer from a secondary lactose intolerance. Therefore, it's always important to re-challenge with lactose. So the clinical presentation of lactose intolerance, I already briefly discussed it. Infants are more prone to develop diarrhea, and the stool pH is acids. And older children and adults, there will be reabsorption of fermentation products, which reduces the osmotic load and significantly reduces diarrhea. So for children aged 10 to 12 years, the incidence of diarrhea is not that frequent, only 2%. About 6% will suffer flatulence, 15% will have nausea, abdominal distension, more than 20%, and abdominal pain, more than half of the children. What about low lactose diets and their evidence on their role in lactose intolerance and abdominal pain in children? So the amount of lactose needed to induce symptoms in a child with lactose malabsorption is in fact unknown. So on a general basis, it has been established that lactase non-persistent children and adults still can consume lactose without symptoms of intolerance, but the tolerable amounts are variable and depend on several factors. It is said that up to 12 grams of lactose in a single dose can be well tolerated, and when combined with a meal and or distributed over the day, even higher amounts are well tolerated by many maldigesters. And 12 grams of lactose is really a high amount. What about abdominal pain? The role of carbohydrate malabsorption in the pathogenesis of abdominal pain still remains a matter of discussion and needs further investigation. Carbohydrate malabsorption appears to be an incidental finding in children with functional abdominal pain rather than its cause. And lactose reduction has no clear benefit in functional abdominal pain, according to some of the data. Why is it best to continue to administer some lactose to the children? Well, as said before, because lactose has an effect on the gastrointestinal microbiome. And what this slide shows is that lactose increases the counts of commensal bacteria, and lactose decreases the counts of pathogenic bacteria. This in children with cow's milk allergy, which were fed an extensive hydrolysate with decreased amounts of lactose, but with some lactose present. So in that condition, lactose clearly has beneficial effects. It's also illustrated on this slide, showing that purified lactose in a similar proportion to breast milk can further improve palatability and help promote a healthy gut microbiota and calcium absorption. Again, the increase of in lactobacilli is clearly illustrated, and what is also shown is a better calcium absorption. And that is, of course, important for that child of 1 to 5 years old to have an optimal calcium absorption. That brings me to conclusion of my presentation. So milk is an essential nutrient, or at least important nutrient, in infants and in toddlers up to the age of 5 years. The recommended intake, depending on country to country, is 300 to 500 milliliters per day of milk. And that's important for energy intake. Now, growing up milk is recommended to reduce the protein content. That's a different discussion. Vitamin D is offered through growing up milk. Iron is an important in the milk consumption. And of course, calcium is the most important nutrient which is delivered by milk. In secondary hypolactasia, restricted diet is necessary only for a limited time. But as I said before, we don't know how long that limited time is, in fact. In primary lactose intolerance, lactose-containing dairy products are generally avoided for 2 to 4 weeks, the time required to induce symptom remission. Then, a gradual reintroduction of dairy products low in lactose, that's important, up to a threshold dose of individual tolerance should be recommended. And children with primary lactose intolerance have varying degrees of lactase deficiency and often tolerate varying amount of dietary lactose. No scientific evidence is available to identify the tolerable dose of lactose for children with lactose intolerance. And reduction of lactose intake rather than full exclusion is recommended in lactose intolerance. So milk contains about 4.5% of lactose, or 45 grams per liter. The recommended intake for a toddler is about 300 to 500 milliliters. So let's take 400 milliliters of milk a day, which is about 18 grams of lactose. Symptoms are known to develop in 70 to 90% of those with late onset lactose intolerance if they ingest 50 grams. And in 30 to 60%, symptoms will already develop if they ingest 10 to 15 grams. So as already said, there are different grades of lactose intolerance, and it's considered to be severe if you only tolerate 0 to 2 grams, medium severe if you tolerate 2 to 7 grams, and low severe if the amount tolerated is equal or more than 12 grams. And tolerance is when you tolerate equal or more amount than 20 grams of lactose. So 400 milliliters of milk is about 18 grams of lactose, which is about the 20 grams for tolerance. Now, if you give a growing up formula with reduced lactose, then with only 10% of lactose, then the amount of lactose administered is 1 gram of lactose, let's say 2 grams, which means that only the very rare, very severe cases of lactose intolerance will maybe not tolerate the 400 milliliters of that milk with 10% of lactose. But the vast majority of the children, the toddlers with late onset lactose intolerance, will tolerate the growing up milk 400 milliliters a day with 10% of lactose. So recommendation in toddlers is about 400 milliliters of milk a day. Milk is an important nutrient for toddlers, and low lactose growing up milk reduces the symptoms of lactose intolerance and is therefore recommended. I would like to thank you for listening to this webinar.
Good afternoon, everyone. Thanks for joining us today for this webinar. Thanks to Dr. Vandenplas for such extraordinary presentation. Now, Dr. Vandenplas is joining us for question and answer. Remember that you can ask in Zoom in the area of question and answer, and also via YouTube. Well, doctor, thank you. Welcome. I know this is a little late for you in Belgium. So I have some questions that I want to share with you. You said in your presentation that there is still unknown the time of the recovery for the epithelium for injury in a secondary lactose intolerance, right? So
yes.
how do you know when you can fully introduce lactose to the patient?
Yeah, well, first of all, good evening to everyone. It's indeed quite late already here in Brussels. To answer your question, well, that's a very good question to which there is no scientific answer, because there is no literature available on the duration needed for the gastrointestinal mucosa to recover. So that's why it's considered that you should then reduce lactose for a certain period, which seems reasonable. And up to 1 month is certainly a reasonable period to have reduced lactose intake. I don't think it needs to be 0 lactose during that period, because most of the time a certain lactase activity remains. But you're absolutely right. This is a shortcoming in research, that we do not know after an infectious gastroenteritis or whatever other disease, such as celiac disease or cow's milk protein allergy, how long it takes for the mucosa to recover. Probably a couple of weeks, but we do not know.
Okay, but maybe the symptoms when you're trying to introduce lactose is not improving, or something like that clinically, the clinical point of view, I mean.
Yes, that's certainly a way how you could test it, is to reintroduce lactose relatively rapidly, and then if symptoms relapse, you know that the child did not yet recover. But of course, what everyone wants is to reintroduce lactose only when the child will again tolerate it. So there is certainly a trend to make the duration of lactose reduction relatively long after such a period, to not make the child sick every time again.
Another question is reducing sugar test in stool, clinical value really for lactose intolerance.
Well, it's a good test to diagnose carbohydrate malabsorption, but it is not specific for lactose, of course. So the presence of reducing sugars means that not all carbohydrates are absorbed. That's true, but so it's a test for carbohydrate malabsorption, but not specifically for lactose.
Okay. Another question, doctor, is the possibility of lactose intolerance of producing a speed up?
Sorry?
A speed up. Lactose intolerance produce a speed up?
I don't understand the last word, sorry.
A speed up.
I don't get it, sorry.
No, Gary? No, that's okay. Another question is, what infant and toddler milk would you recommend for lactose intolerance, extensively hydrolyzed or one with bifidobacterium?
Well, in case of lactose intolerance, I would recommend formula with reduced lactose content. It does not necessarily have to be hydrolyzed protein because there is no problem at all with the digestion of protein in case of lactose intolerance. And bifidobacteria are always healthy to stimulate the development of bifidobacteria gastrointestinal microbiome, but they have also no real impact on lactose absorption.
Okay, another question is, kindly repeat the recommended tolerable levels per milliliters of milk that can be given to an infant or toddler in the first category of lactose intolerant?
Well, the recommended daily intake for a toddler is about 400 milliliter, but if you give regular milk, then you give almost 20 grams of lactose, which is too high. So that's why if there is lactose intolerance, you need to give a different growing up formula with low reduced lactose, because otherwise the amount of lactose or amount of milk tolerated will be below the daily recommendations for calcium intake and the daily recommendations for milk intake.
Okay, what does he suggest can help to improve the recovery time after diarrhea episodes to be able to introduce lactose to the diet?
Yeah, that's a very good question, again, to which we have no answer, because there are no real studies on the speed of recovery. We know that probiotics may decrease the duration of gastroenteritis. That has been shown for some of the strains, that you get a decrease of the duration by about 1 day. For some of the probiotics, more specifically yeast probiotics, Saccharomyces boulardii, some effect also on the growth of the intestinal mucosa has been shown. But there are no data on the effect on acquisition of lactase activity. So it's clearly an area in which data are missing. If I give probiotics in an acute gastroenteritis, is the duration of lactose intolerance, lactase deficiency really shortened or not? That has not really been studied up to now.
Okay. What is the difference in symptoms between cow's milk allergy versus lactose intolerance in babies?
Well, some of the symptoms may be similar, but the cow's milk allergy may have, of course, much broader symptomatology than lactose intolerance mean? Cow's milk protein allergy can also cause atopic dermatitis, can cause respiratory symptoms, and it's clear that lactose intolerance will only cause gastrointestinal symptoms, mainly gasiness and diarrhea, while cow's milk allergy can cause gastroesophageal reflux, can cause diarrhea, that's for sure, but can cause constipation as well. So a subgroup of the children with cow's milk allergy may present with the same symptoms as those with lactose intolerance. But the vast majority of children with cow's milk allergy present with symptoms in different organ systems. So it's a combination of gastrointestinal and skin manifestations, or gastrointestinal and respiratory manifestation. And of course, lactose intolerance will only give gastrointestinal symptoms. But again, that does not exclude that a child with cow's milk allergy may have respiratory symptoms, and that altogether or in combination, there is also lactose intolerance which cause the gastrointestinal symptoms, because of course you cannot separate the gasiness and diarrhea caused by cow's milk allergy by that of lactose intolerance, because those gastrointestinal symptoms caused by cow's milk allergy are the consequence of damage to the gastrointestinal mucosa. And so as a consequence, there is a secondary lactase deficiency in those children with cow's milk allergy.
Okay. It is okay to take lactase and drink milk if you think you are lactose intolerant?
Yes, that's another solution, which is safe and probably relatively effective to do, is to take the missing enzyme before you ingest the lactose.
Okay, doctor, what do you think about soy-based?
Yeah, well, soy does, of course, not contain lactose. So if it's the question soy to in the management of lactose intolerance, that's fine. But as I tried to explain in the presentation, it's also important to ingest some lactose for the effect of the lactose on the gastrointestinal microbiota, because it stimulates the lactobacilli and bifidobacteria, but especially lactobacilli are important for calcium absorption. So soy is, of course, a good choice for management of lactose intolerance, but continue to administer low amounts of lactose are preferable to no lactose at all. And if the question was focusing on cow's milk allergy, then I would say that the first recommendation in the management of cow's milk allergy is an extensive hydrolysate. But if that is not available, or if the child refuses to drink it, or if it's too expensive, then soy is for me a good second choice option in the management of cow's milk allergy, because it will still be effective in about 80 to 85% of all the infants.
Excellent. Well, I don't have more questions to Dr. Vandenplas. So I just want to say thank you, doctor, again, to take your time. I know it's late for being here with us today. And basically to all of you to share it with us this afternoon, and wish you all a very good night. Thank you.
Thank you very much.
Bye-bye.
Bye.